Neutropenic sepsis. Neutropenic sepsis is a medical emergency defined as a life-threatening infection in patients with a neutrophil count less than 0.5 times 10 to the 9 per liter and a fever of at least 38 degrees Celsius, or other clinical features of sepsis. It most frequently occurs after chemotherapy due to bone marrow suppression, but can also arise in other settings of impaired neutrophil production or function. Peak incidence. Most commonly presents 7 to 14 days after chemotherapy when neutrophil counts are at their lowest. Common in patients with hematological cancers, solid tumours undergoing chemotherapy, or those with bone marrow failure syndromes. The most frequent pathogens are gram-positive bacteria, particularly coagulase-negative staphylococci, Staphylococcus epidermidis, though gram-negative organisms and fungi are also significant. Pathophysiology. Chemotherapy-induced marrow suppression is the leading cause, reducing neutrophil production and impairing host immunity. Underlying conditions, for example leukemia, aplastic anemia, congenital neutropenia, and post-stem cell transplant, predispose to neutropenia. Infection risk is heightened by mucosal barrier breakdown, oral ulcers, mucositis, GI tract damage, indwelling lines, and hospital-acquired pathogens. The absence of neutrophils reduces the body's inflammatory response, allowing rapid progression to severe sepsis and shock. Symptoms: fever of at least 38 degrees Celsius in a patient on chemotherapy or other myelosuppressive treatment. Flu-like symptoms: shivering and dry gauze, sore throat or painful mouth ulcers, shortness of breath, abdominal pain or diarrhea, dysuria, and confusion, especially in older patients. Signs: fever or hypothermia, tachycardia, hypotension, tachypnea or hypoxia, reduced urine output, agitation or confusion, and localized evidence of infection, for example cellulitis and infected central lines. Diagnosis: neutropenic sepsis is a clinical diagnosis and treatments must not be delayed for investigations. Full blood count. This confirms neutropenia less than 0.5 times 10 to the 9 per liter. Blood cultures, ideally taken before antibiotics. Serum procalcitonin, if available, may help distinguish bacterial infection from non-infectious fever. Other microbiology: urine culture, sputum culture, stool culture, and swabs from wounds or catheter sites. Imaging: chest x-ray to look for pneumonia, and CT scan if abdominal symptoms or suspected occult source. Complications: septic shock, multi-organ failure, disseminated intravascular coagulation (DIC), acute respiratory distress syndrome (ARDS), and death. Management: immediate action is essential. IV antibiotics must be given within 60 minutes of first suspicion. Sepsis 6 bundle within 1 hour. oxygen to maintain saturations 94 to 98%, take blood cultures, give IV antibiotics, administer IV fluids, check serum lactate, and monitor urine output. Empirical antibiotics per the local guidelines. First line, IV piperacillin tazobactam, tazocin. If still febrile after 48 hours, escalate to meropenem plus or minus vancomycin. If fever persists beyond 4 to 7 days, consider antifungal therapy. Additional measures. Granulocyte colony stimulating factor, GCSF, may be used to accelerate neutrophil recovery in selected patients. ICU referral. This is indicated if patient deteriorates or shows organ failure. Prognosis. Mortality is high if treatment is delayed. With prompt antibiotic therapy and supportive care, outcomes improve significantly. Prognosis worsens with prolonged neutropenia, resistant pathogens, or delayed recognition.
That was the full video, and there's hundreds more like it waiting for you at finalmed.co.uk. Get over 9,000 UKMLA exam questions, hundreds of animated videos, and our trusted textbook all in one platform designed to make your revision faster, clearer, and exam focused. Start your free 7-day trial today